Hi, my name is Douglas Simonetto, and I'm an assistant professor of medicine in gastroenterology and hepatology at Mayo Clinic in Rochester, Minnesota. And on behalf of my co-authors, I'm happy to share our article entitled Prevalence and Predictors of Third-Generation Cephalosporin Resistance in the Empiric Treatment of Spontaneous Bacterial Peritonitis. Current national and international guidelines recommend empiric treatment for SBP with third-generation cephalosporins until microbiology results from the acidic fluid are available to guide antibiotic selection. Recently, however, an increasing prevalence of gram-positive bacteria and third-generation cephalosporin-resistant strains have been observed in European studies. Similar studies had not been done in the United States to date, and this changing pattern may not be reflective of our local microbiota or antibiotic use. So the purpose of our study is to better characterize the changing patterns of SBP in a tertiary academic center in the United States by identifying the prevalence of gram-positive organisms, the frequency of cephalosporin resistance, and identify potential predictors of mortality and antibiotic resistance. In this study, we reviewed 481 consecutive patients from Mayo Clinic Rochester between 2005 and 2016 with a diagnosis of cirrhosis and confirmed diagnosis of spontaneous bacterial peritonitis. And we identified 96 patients with culture-positive SBP. 53% of them were healthcare associated, 38% were community acquired, and 9% were nosocomial acquired. Gram-positive organisms accounted for the majority of cases, about 56%, followed by gram-negative organisms and Candida species. The most common gram-positive organisms were Viridans streptococci at 42%, followed by Staphylococcus aureus at 13%. E. coli and Klebsiella were the most common gram-negative organisms identified. We also found a higher rate of Enterococcus species, mainly E. faecalis, in the nosocomial SBP group at 22%, compared to 2% in the healthcare-associated and none in the community-acquired groups. For treatment, third-generation cephalosporin was the most common empiric treatment prescribed at 42%, followed by piperacillin tazobactam and vancomycin. Overall resistance to third-generation cephalosporin was 10%, 55% in the nosocomial acquired, 8% in the healthcare associated, and 3% in the community acquired groups. Risk factors for third-generation cephalosporin resistance included nosocomial acquisition, recent antibiotic use, and a history of a hepatocellular carcinoma. Diabetes and a recent history of GI bleeding were not associated with increased resistance rates. Based on these risk factors, we developed an algorithm to help identify patients with third-generation cephalosporin resistance. This algorithm performs with a sensitivity of 70% and a specificity of 81%, and a positive predictive value of 30% and negative predictive value of 96%. Median survival in our cohort was 11 months after the diagnosis of culture-positive SBP. The overall mortality at 30 days was 30% and up to 37% at 90 days. The highest 90-day mortality was observed in the nosocomial acquired group at 67%, followed by 40% healthcare associated and 25% in the community acquired. A prior history of SBP and HCC were associated with increased mortality, whereas a serum albumin level was associated with lower mortality. In conclusion, our study supports the recent observation of rising incidence of gram-positive organisms in SBP. Despite the changing pattern, third-generation cephalosporin still provides adequate empiric treatment in community-acquired and healthcare-associated SBP and in the absence of hepatocellular carcinoma. Broader spectrum antibiotics should, however, still be considered instead for hospital-acquired, recurrent SBP, and for patients with underlying malignancy. Thank you.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.